Hello, hello, test. Good afternoon, ladies and gentlemen. Thank you for coming today. Just before we start, I would like to introduce the chairman of our organizing committee for the Exercises Medicine Month, Dr. Michael J.
Hey everybody, welcome to the talk today. First, I'd like to say that this seminar is put on by the Center for Sport and Exercise as well as the State Key Laboratory of Biotechnology and Pharmaceutical. It's my pleasure today to really invite Rob here. Rob's an old friend. We've known each other since 25 years probably when I met in Philadelphia. But you know, Rob's an excellent researcher. He's now the Associate Dean of Medical and Exercise Science at Edith Cowan University. And he's also the co-director of their Exercise Medicine Research Institute. Aside from being a really good researcher, I gotta say one thing about Rob is he's a super humble guy, and he's if you have a chance to meet him, he's a great guy, and he's always great to his students, and actually really a good collaborator as well. So I know he has many things to say. So I'd like to introduce Rob up here. Please give him a warm welcome.
Thanks, Michael. Very much appreciated. And while the AV gets set up, I just really want to acknowledge my thanks to Michael for a 25-year collaborative relationship and friendship. It's always a pleasure to come to Hong Kong. I'm particularly proud to come to Hong Kong University because I am an honorary professor of this esteemed university, realising that this is one of the best universities on the planet. So it's a great honour for me to be able to come and present in this very auspicious building. So thank you very much, Michael. So I've got lots to talk to you about, so let's get going. So for the last 20 years, my team and I have been researching an exquisite medicine. This medicine benefits every organ system in the body. It's proven effective in treating, or in fact, in some cases, curing almost every chronic disease. Unlike any pharmaceutical, there are no known side effects of this medicine. This medicine is exercise. Exercise is medicine. And it's fantastic to see the university bring Exercise is Medicine to campus here for this month of really impressing about the importance of exercise as a medicine, probably a key medicine which is going to help us to move forward to address the major health issues that we currently are being confronted by. So I just want to give some definitions first, and this is from the World Health Organization because it's very important that we understand the differentiation. Physical activity is any bodily movement produced by the skeletal muscles that requires energy expenditure. But the WHO is explicit that the term physical activity should not be used interchangeably with exercise. And this is an important definition or distinction that we need to recognise moving forward. Because exercise is a subcategory of physical activity. It's planned, structured, repetitive, purposeful in the sense that the improvement or maintenance of one or more components of physical fitness, physical structure, or amelioration of disease is actually the objective. So it seems strange to think of exercise as a medicine. It's not surgery. It's not a pharmaceutical drug. But exercise medicine is a physical assessment and prescription of exercise specifically for the prevention or treatment of injury and illness. And we can speak of it as a medicine because it drives endogenous medicine within our body. When we exercise, we have dramatic changes in the biochemical milieu within all of our body systems. Dramatic changes. Changes in our hormones, cytokines, and a whole range of other signaling molecules. Changes in temperature, changes in the forces going through our various structures which produce dramatic changes in our actual physical structure. And one of the key things, of course, is that it provides an enormous stimulus to our immune system. And we'll see some more about this when we look at the treatment of cancer. It also produces changes in blood perfusion and vascular adaptations. And this is particularly interesting when we come to explore why exercise actually suppresses tumour growth, because we'll see that it actually causes changes within the tumour tissue itself. And of course, it facilitates other therapies, and it ameliorates many of the side effects of more traditional treatments. So some of you will be sitting in the audience asking, well, is this exercise medicine a new thing? We're starting to hear a lot about this. We're being told we need to do more physical activity. As a public health message, this is one of the major messages that government and other organisations are trying to push out, that we need to get our people off the couch, less sedentary behaviour, more movement. And now we're hearing about exercise as an actual medicine to manage some of the major diseases which are killing the vast proportion of our populace. Well, it's not a new thing, in fact. It's very ancient science. And the early reporting has been in as far back as the ancient Greeks, where there was a very strong philosophy around the use of exercise for maintaining normal health. And the famous story of Milo and his calf. He started out as a young boy carrying a calf, and then as the calf grew bigger, and of course he grew stronger. And that was the first record of progressive resistance training back with the ancient Greeks. But then through the subsequent millennia, there has also been a strong emphasis on physical activity and exercise for maintaining health, but in particular to improve performance. And the greatest boost, of course, came with war. Because starting back early in the last century, there was an enormous amount of research conducted to try and determine how to actually build a better warfighter. How do you build a better soldier? And that, of course, has been continuous over many, many decades now, trillions and trillions of dollars invested in how you actually make a human perform better in a war. Of course, we have athletes as well. As you all know, the modern professional sport environment is a multi-trillion-dollar US industry. It is absolutely massive, the amount of investment that goes into how do you make an athlete better? How do you win a gold medal? How do you win an NBA final? So again, huge amount of investment. Many of you in the audience are exercise scientists, exercise physiologists, and you know the number and volume of high-quality scientific journals which are in this discipline. So this is not a new discipline. It's a very old discipline with a very, very large knowledge base. And then one of the greatest boosts in terms of research into human performance, exercise, was, of course, space. So back in the 50s, when we started to push out into space exploration, again, governments investing billions, if not trillions of dollars in trying to understand how can we make a human being survive in the harshest environment in the known universe. All of this knowledge is now being applied into patient populations. We know so much about the human physiology and how it responds to exercise. We're now starting to apply that in the actual management of cancer, cardiovascular disease, type 2 diabetes. So we need to make that distinction between physical activity, which is very, very important, and if we can get our peoples of the various countries to meet minimum physical activity recommendations, yes, we will see an enormous reduction in chronic disease. But then we have targeted exercise specifically prescribed to actually help people survive cancer, cardiovascular disease. We've got a problem, as you all know, as Hong Kong does as well, in that we're inundated with our health system. Chronic non-communicable diseases, currently responsible for around 70%. It's now up to around 80%, actually. There's a bit of an old data. I have to update my slide. Of the total burden of illness. So it's no longer communicable disease, which is causing death and morbidity, but it is, in fact, diseases we don't have to have. They're lifestyle diseases. So what is a chronic disease? Many of you will know this. It's slow progress, long continuance. It's not until the individual crosses the threshold, which is called the clinical horizon. In many cases, they won't realise that they actually have a disease. So diagnosis being hypertensive or having high blood glucose, having cancer, or having actual heart attack. But the mechanisms underlying this process have been going on for decades leading up to that clinical horizon. The major risk factors for chronic disease, if we could eliminate them, at least 80% of heart disease, stroke and type 2 diabetes prevented. 40% of cancer would be prevented. The risk factors are simple: unhealthy diet, physical inactivity and tobacco use. So it comes down to a fairly simple solution. The difficulty is actually implementing that solution. So clearly we need a new approach. Whilst we work very, very hard in research to find new ways to manage cancer or type 2 diabetes, we will never be able to keep up with the lifestyle changes that is occurring with modern human beings. And so we'll only see more and more people falling to chronic disease. We need to look at prevention and treatment through lifestyle modification. So we're at a stage now where poor diet and physical inactivity will soon overtake tobacco as the leading causes of death in Australia and the United States. Some conservative estimates. This is the protective effect of physical activity, not exercise medicine, but physical activity. All-cause mortality, a 30% risk reduction. Cardiovascular health, 20 to 35% lower risk. Metabolic health, 30 to 40% lower risk for type 2 diabetes and MET syndrome. We'd reduce falls by 30% with regular physical activity. Cancer prevention, around 30% for breast cancer, 20% lower risk of colon cancer. Even mental health is intimately tied to our sedentary behaviour as well. We are made to move. And in fact, if we get people to be more physically active, we'd actually reduce depression and dementia. So how are we doing in terms of this? The message is pretty clear, but what's actually happening in Australia? Well, this is some relatively recent data, 2015, from our Australian Bureau of Statistics, and they're showing that only around 1 in 2 adults between 18 and 64 participate in sufficient physical activity. That's only 20 minutes of physical activity per day. It's not a huge ask. We're only meeting about half that now. And if you see there, the actual percent actually gets worse in terms of insufficient physical activity as we get older. We have issues in that people, particularly once they get past 45, there is even more sedentary behaviour. So the question which is often asked is, what's going wrong? Got better medical care than we've ever had before, better sanitation, very strong public health awareness around the problems of alcohol and tobacco use. The issue is that the human genome, as you all sit there, has evolved over at least the last 45,000 years with an environment of very high physical activity. So the current human genome expects and requires humans to be physically active for normal function and health. That is what your underlying genome requires. If you have a look at your genome, what it is actually has evolved under is the conditions of a hunter-gatherer. So you would be, if you think of the Australian Indigenous peoples, pre-European invasion, they would have spent their entire day on the move. They would have walked very large distances because they had to search for food. They had to carry very heavy things. They had to carry food. They had to carry part of their house, kids, you name it, had to be carried. So they had to lift heavy things. They had to run very fast to chase something down that they wanted to eat. They had to run very fast to get away from something that wanted to eat them. So they're the sort of conditions in which we as humans have evolved. And our genome has not changed in the subsequent 45,000 years. So our underlying physiology requires us to be physically active on most, if not every day. So some major chronic diseases and the role of exercise. I'll go through these relatively quickly because many of you will be aware of this. One of the key issues we have facing our older population is sarcopenia. Because they're physically inactive, in particular, they do relatively low intensity activities such as walking. It means that they're compromising their neuromuscular system. And the prevalence of low muscle mass and functional decline is about 60% in those Australians over the age of 80 years. This is a major cause of loss of independence. And once you lose your independence and your functional ability declines, then it's a very rapid spiral downwards in terms of your health. And of course, a greatly increasing cost to our healthcare system as well. How do we counter this? Well, anabolic exercise or resistance training is the only way, in fact, that we can counteract this, and been shown to be very, very effective at preventing or even reversing sarcopenia. Osteoporosis is also on the rise, most of the Western countries of the world. And this is despite all the push for eat more dairy, take more calcium, take more vitamin D. Of course, lifelong physical activity has a strong preventative effect. Anabolic exercise or weight training is the greatest efficacy, and I'll just present one study there. It was 1 year strength and endurance training. These are in menopausal women, 1.3 increase in bone mineral density in the training group, a 1.2% decrease in the control group. All participants were supplemented with vitamin D and calcium in this study. Vitamin D and calcium is of no value unless there's actual physical stimulus to the bone to cause it to actually lay down more bone tissue. Osteoarthritis. It wasn't so long ago that if you had osteoarthritis, you were told to rest, try not to overextend the limb or place too much stress on it. We now know that exercise is absolutely critical in the management of osteoarthritis. It increases function, reduced ratings of pain, reduced stiffness, and in particular, again, strength training, anabolic exercise reported to be safe, effective and well tolerated in people with osteoarthritis. Obesity on the rise. We see it all over the media. It's obviously a critical public health issue. Exercise and diet modification is the only long-term solution to weight loss and lasting weight loss. Interestingly, exercise is not very effective to lose fat. You can increase your amount of physical activity markedly and you don't tend to lose terribly much fat tissue. Diet modification is the most effective way, so actually reducing the caloric intake to help you to lose fat. The problem with diet modification is it's not just a fat loss program. When you diet, it is also a muscle loss program and a bone loss program. Again, the only way to counteract that is to perform physical exercise, and you'll be able to prevent totally the muscle and bone loss that occurs with diet restriction. The other thing is it's hard to lose a lot of weight on diet alone because you're hungry all the time. One reason is, a kilogram of fat is equivalent to about 32 megajoules of energy. So you could just reduce, because the recommended weight loss, healthy weight loss is around 1 kilo per week. So you could just reduce your dietary intake by 32 megajoules a week, but you're going to be a little bit hungry. Or you could reduce it by 16 megajoules and increase your physical activity by 16 megajoules. You get the same energy imbalance, but you get some other metabolic effects which are quite nice, and also you don't have the issue of muscle and bone loss. The key though is that we need to be careful about focusing purely on fatness. It's actual fitness that produces the protective effect in terms of, in particular, cardiovascular disease and metabolic syndrome. It's not the actual physical appearance of being overweight. And we've got to be a little bit careful if the message is all about fatness. Because, for example, we see, a very big trend in Australia now is gastric banding, which causes, in the majority of patients, not all, it causes, very effective weight loss. But again, it also causes loss of muscle and bone. If they then don't take up physical activity, it doesn't greatly reduce their risk of getting a wide range of other diseases than diabetes. So you've got to be a little bit careful at the messages there. Exercise and cardiovascular disease. When I started in this 35 years ago, when I was an undergraduate student, people were told if they had a heart attack to go home and rest, don't do any physical activity, please do not lift any weights because that'll kill you immediately. And of course the result was that they were either back in hospital 6 months later or they had another infarct and were dead. So that's changed, as you know, entirely. In cardiac rehab now, the patient's up and exercising as soon as possible. We get them out of the bed as quickly as we can, get them moving, including lifting weights. Anxiety and depression. I'll just give a very nice study here by Nail and Singh's group out of the University of Sydney here. I like this study because they took older folk and they had them counselled by or assessed by a clinical psychologist, and then they had those that were diagnosed as being clinically depressed. They then randomised them to 3 different groups. The first group, they said, go back to your GP and tell him or her that you've been diagnosed with clinical depression. And they get routine GP care, which would most likely be a pharmaceutical in some form of antidepressant agent. The second group, they got them in a group format and they had them lifting light weights, your typical light weight exercise that you do for older people. And then the third group, they had them again in a group format, but they were lifting heavy weights. So to the result, well, routine GP care works. It was about a 25% reduction in ratings of global depression. But interestingly, just putting in a group exercise classes with light hand weights produced a 40% reduction in depression. And in fact, lifting heavy weights produced almost a 60% reduction, so more than double the effectiveness of routine GP care. So there is something particular about exercising when you're lifting the heavier weights that produces a more effective benefit in terms of depression. We now know that when we exercise lifting heavier weights, we get a nice surge in testosterone. Testosterone is very anti-depressive, but also other factors like brain-derived neurotrophic factor, a whole range of other signalling which goes on, which seems to indicate that yes, exercise is effective, but particular exercise is more effective than others. Type 2 diabetes, obviously, again, really on the increase. I spoke to a doctor the other day, and he just wanted to give metformin to everyone on the planet, anyone over 14, I think, which is not a criticism, but that's the best tool we've got at the moment in terms of pharmaceutical drug. And it is effective, but it also has a wide range of side effects, and it doesn't address all the other aspects of health not related to high blood sugar. But exercise improves insulin resistance. It's effective for both preventing and treating type 2 diabetes. And in these patients, because they're often older, obese, and have a lot of comorbidities, aerobic exercise is not terribly well tolerated. So most of our drive now is to use resistance exercise or high-intensity intermittent training in this patient population. Several studies now have shown that appropriate exercise prescription can take someone from being a frank diabetic to being pre-diabetic and even back to being totally normal glucose metabolism. So exercise currently is the only cure for type 2 diabetes. Metformin is not a cure. Metformin is simply a drug which holds their glucose down. Alzheimer's disease is an interesting one. We've done some interesting work in this area, finding that exercise is quite effective at reducing your risk in the general population, reversing or slowing progression in the early stages, but then in later stages in maintaining quality of life, structure and function. This is just one study here. These were groups of individuals, fairly large study, tracked over time here, and all they did was separate them into those that did 3 or more times exercising per week for those that did 3 or less. And you can see in the plots here a very rapid separation with the people exercising less than 3 times per week developing dementia at a much earlier age. So we'll move on to my particular area of research interest at the moment, which is the application of exercise as a medicine in the management of cancer. So this is a very nice diagram from Kerry Cornier's group in University of Alberta, and it looks at the actual specific phases along the cancer continuum and the application of exercise. Of course, pre-diagnosis here, exercise is very important because we know that exercise will actually reduce your risk of developing a wide range of cancers in the first place. But also in terms of pre-screening and detection, we're seeing increases in certain cancers and also diagnosis of cancers at a later stage because people are more overweight. Because they're more overweight, they can't actually physically palpate the cancer as effectively as we could decades ago and we're thinner. The other thing is a lot of imaging also is not as accurate in someone who is morbidly overweight. So important here to exercise pre-diagnosis, but then the patient gets the unfortunate diagnosis of cancer, and then we're looking at application immediately here. This is a teachable moment, as it's called. The patient has obviously a considerable fear that they're going to die, which is quite reasonable. And so this is a time when you can say, look, these are the treatments you're going to go through, but it's also an opportunity to change your lifestyle. If you change your lifestyle, you are going to greatly increase your chances of surviving this thing. So in treatment preparation here, we're applying exercise as a medicine leading up to surgery. And I can't present the data today for time reasons, but we've been doing several studies in breast cancer, ovarian cancer, and prostate cancer. And we're about to launch a study in cystectomy, the removal of the bladder due to cancer, and finding very good application of exercise to prepare the patient. So if you can imagine going for cancer surgery, that's like going out and running the Hong Kong Marathon. So you're not going to sit at home watching television and eating cheesels or something. Cheesels, does that translate? eating corn chips, leading up to and then race out on the day of the Hong Kong Marathon and go for it. All right? The surgery is a challenge far greater than the Hong Kong Marathon. You need to be resilient for it. You need to be fit for it. And so we're preparing the patients here. If there's specific issues, for example, around a lot of the gynecological cancers or prostate cancer, there's issues around continence, so we spend some time there, just doing the exercises which will help them to be continent post-surgery, which is important. Also, leading up to chemotherapy or radiation therapy, you want the patient fit. Some very nice research published this year showed that there was a direct relationship between the amount of muscle mass that the patient had and how many chemotherapy toxicities they experienced. It appears that the more muscle you have, the less toxic the chemotherapy is to other healthy tissues. So then you're in treatment here, and again, we're exercising our patients throughout chemotherapy and their radiation therapy. It wasn't so long ago they were told to rest during this phase. You've got fatigue, you need to rest. We now know that it's the reverse. If you do rest, the fatigue will only be worse. And so we exercise them. Then recovery, of course, their fitness will be decreased. They'll have issues around their body structure, such as reduced bone density, reduced muscle mass. They may have increased fat if they're receiving hormone therapies or immunotherapies. And so this is a recovery phase application of exercise to rehabilitate the patient. And then we have this, they're now classified as a survivor. They no longer have cancer. But the greatest fear they have is that it will recur. And very solid research showing that being physically active will actually reduce the risk of recurrence. And then at end stage of life, again, we're applying exercise to these patients to help them mainly to maintain some quality of life. But also, there's 2 very large studies running internationally now to see if it actually extends their survival as well. So just a very quick slide on physical activity and cancer risk. If you have a look at colon cancer here, it's around a 20% reduction, 30% reduction for breast cancer. Prostate cancer, particularly older men in advanced form, 70% reduction in risk if they do 3 hours or more of vigorous activity per week. So we've got to keep active trying to get cancer in the first place. Here's a very interesting editorial, and it was in Journal of Clinical Oncology, which is the top 2 or 3 journals in the world in cancer research. And the editor wrote, "Cancer survival, time to get moving, data accumulates suggesting a link between physical activity and cancer survival." Wow, that's pretty powerful. And here we have a range of studies. This is a meta-analysis of a range of studies, predominantly in breast, colorectal and prostate cancer here, and just showing the effect estimate in terms of the post-diagnosis and cancer-specific mortality. And what we see is that if the patients hit a certain level of physical activity, it actually reduces their risk of dying of the cancer. Okay, not dying of MET syndrome or cardiovascular disease, but actually dying of the cancer. And when you average it across all these studies, the pool relative risk was 0.63 here. So that's a considerable survival advantage. So the editor of JCO wrote that the data suggests a reduced risk of recurrence or death by around 50 to 60%. So a lot of people ask, well, is that good? Well, the editor of the top cancer journal in the world wrote, "Such an effect parallels that of Herceptin, an agent heralded by the oncological care community and the director of the National Cancer Institute as a major advance and turning point in eliminating suffering and death from cancer. And yet hitting a certain level of physical activity produces a similar survival benefit." Of course, the key is that exercise will never cure cancer. So don't give up the chemotherapy. But exercise is not an alternative, but a critical synergistic medicine to chemotherapy and other cancer treatments, as we'll see in a moment. So if the patient exercises after they've been diagnosed with cancer, they have a reduced risk of dying of that cancer, and it's a considerable reduction. How does this happen? What is going on here? Well, in 2016, we wrote a paper which we published in European Urology, Nature Reviews Urology. We proposed 10 mechanisms by which exercise actually suppresses or alters tumour biology. And I don't have time to go through all of them, but I'm happy to receive questions on them. We've added another 2 to these as well. But, such things as changes in circulating factors like insulin growth factors and sex steroid hormones. Improved immune function is a big one here as well. So we'll delve into a few of these. So this is a nice study, and this was done in women receiving chemotherapy for their breast cancer. And there was 3 groups. The first group was usual care, and then there was 2 groups. One did low-intensity exercise, the other one did higher-intensity exercise here. Now, what we observed in the usual care, so this wasn't our study, but the authors observed, was around a 25% reduction in chemotherapy dose. So when it's decided, and you accept that you're going to take chemotherapy, the oncologist, the medical oncologist, will map out a course of treatment. But in 25%, however, the average dose reduction will be around 25% because of the side effects that the chemotherapy produces. And they're quite nasty, things like neuropathy, febrile neutropenia. The oncologist has to back off on the chemotherapy dose. In the groups doing either light or heavy exercise, there was only a 10% reduction. This has to translate to better survival, simply because you're getting more toxic chemotherapy into the actual tumour. So that could help explain why more people survive if they're physically active. This is an interesting study. This was done in healthy males, actually. They cycled for 60 minutes and they drew their blood and extracted the serum pre and post. And then they poured the serum over human cancer, prostate cancer cell lines. In 9 out of the 10 individuals, they observed growth inhibition. When they pooled the exercise serum, there was a 31% inhibition of the actual tumour cell proliferation. So here's the data from this study. This was a 10% inert substance. This is the resting or the pre-exercise serum. No effect. So these substances are not in the blood at rest, but this is after the exercise, and we see a 31% suppression of cancer cell growth. So something is produced, a whole range of substances, some of which we probably don't know what they are yet, is produced when we exercise that have a strong anti-tumour effect. This is another study here. This is looking at the exercise immunotherapy effect. The biggest thing at the moment around cancer treatment is the new immunotherapy drugs which are coming along. What they do is effectively boost the immune system up so the body's own immune system fights the cancer. This was an animal study. In this particular study, they looked at rodents, and they divided the rodents into 2 groups. These rodents were genetically identical. They were fed exactly the same things. The only thing was 6 of them were put in a cage with a running wheel and 6 of them didn't get a running wheel. That's the only difference. They then inject the animals with human melanoma cancer, and then what they looked at was the actual tumour volume when they sacrificed the animals. And you see the massive difference between the exercise and the control animals. The number of tumours in the lungs, because the melanoma tends to grow in the lungs of these animals, much higher in the control group that didn't have access to an exercise wheel. These are the lungs of the sacrificed animals, and you can see the massive difference in the tumour volume between those animals that actually had the opportunity to exercise. So some way here we have a considerable suppression of tumour growth. This is their hypothesis of what's going on here. Of course, when we exercise, we get the production of epinephrine. This drives the mobilisation of natural killer cells. Then, under the action of IL-6, IL-7, IL-15, this causes maturation of the natural killer cells, and then they're actually moving into the tumour tissue, producing the anti-cancer effect here. This is facilitated because of the hypothermia that goes with exercise. When we exercise, our blood temperature goes up quite markedly. This is beneficial. This is a positive thing. We perform better. But it also further enhances the anti-tumour effect. The other aspect too is that when we exercise, the vascularization and perfusion within the actual cancer tissue is improved. Now you might think, oh, that doesn't seem very good. It's just going to give more food to the cancer cells, but that's not what happens. Cancers, as they develop, have very disorganized microvasculature and lower vascular density. And so they tend to be low in blood perfusion and they tend to be hypoxic. Now that, of course, is bad for normal cells. Cancer cells, it doesn't hassle them so much. So when we exercise chronically, what happens is the vascular structure within the tumour is more normalised. And so there's more blood delivered to the tumour, there's more oxygen delivered to the tumour, so it makes our innate immune system more effective, but also it makes chemotherapy more effective. So I've got to keep moving, I'm conscious of time. So this is the increased blood perfusion. This is just one of many studies. Again, this was in animals, but what they did is they had animals here. Half the animals had access to an exercise wheel, and this is the microvessel density within the actual tumour itself. These animals were injected with breast cancer cells. And so half the animals had exercise, half not. Half the animals had chemotherapy and half not. So this is at 0 weeks here, and then we're going up to 18 weeks. This is the control group, which received the cancer cells but no chemotherapy and no exercise. These two groups here, might be a little bit hard to see the two lines, but that's the group that received chemotherapy alone or exercise alone. We see the same rate of growth of the tumour in either of those two therapies. So by this study, in terms of suppressing tumour growth, exercise is as effective as chemotherapy. But this is the interesting thing. When we combine exercise and chemotherapy, we have an additive effect, even greater benefit, and it is probably due to other exercise mechanisms kicking in, but also the exercise helping to facilitate the chemotherapy delivery to the tumour. Turn our attention to one of our early studies here we published back in 2009 in BMC Cancer. This is one of the first studies in exercise with men with prostate cancer who were receiving androgen deprivation therapy. So prostate cancer is the most common non-skin cancer in men, and the most common way to treat it is to castrate the man. So you basically give them chemicals which totally block or stop the production of testosterone. So what we want to do in this study is try and address the problems that occur with castrating a man. And that is loss of muscle mass, which is a real concern, loss of bone density. These men quickly become osteoporotic, and also the decline in physical fitness. So what we did is we put them into 3 different groups. A delayed exercise group here. They did 6 months of just normal lifestyle and then aerobic exercise. This group did resistance and aerobic exercise, and this group did resistance exercise and impact exercise, which I'll show you now. So the impact exercise consisted of increasing levels of body weight force being presented through the skeleton. So skipping, and then we go to single leg, okay, so it's much higher again. Some bounding exercises, a little bit higher intensity. So these are all older men with prostate cancer, and then bounding is the highest level of intensity. This guy at the time of the study was 73. So don't go home and drag your father or your grandfather out of his chair and have you do this. These men underwent 3 months of a very structured exercise program focusing on increasing their strength, making them stronger and their connective tissue stronger as well. But let's turn to the results. So this is the first 6 months, and this is the control or usual care group. They lost over 3% of their lumbar bone mineral density. That is a catastrophic rate of bone loss. That's about 3 times the rate of loss that a menopausal woman experiences. So they're quickly becoming osteoporotic. If they fall and break a hip, they'll be dead within 6 months. This is the group that did the exercise, resistance and cardiovascular. Practically no benefit whatsoever. If I would have run this study, and we have back in the 90s run similar studies, comparing this type of exercise with usual care in menopausal women, we would have totally blocked the bone loss. But it is not the right medicine to overcome the effects of androgen deprivation therapy. It was only the combination of resistance and impact loading that totally blocked the loss of bone. So the key message from this is exercise is not a single medicine. If we were to run this study and only have these 2 groups, we would conclude that exercise is ineffective for preventing bone loss and osteoporosis associated with ADT in men with prostate cancer. But that was simply we were testing the wrong medicine. One of the studies we were then asked to do was in patients with advanced cancer. because still the recommendation, even by the national bodies, was, look, if you're really unwell, you need to rest. So these were patients, in this case prostate cancer patients with advanced metastatic disease. These men are palliative. They cannot be cured at this stage. It is about managing their quality of life and trying to reduce their pain and have some increase in survival. And so these men have metastatic cancer. In other words, the cancer has moved into their bones. And the issue was, well, how do you actually exercise them? Because there's always the concern that they might spontaneously fracture at the site of the lesion. But our oncologists were telling us that the rest strategy is not working. These men are only declining and dying faster. How can we exercise them? So we came up with a protocol here whereby we designed an exercise program that avoided loading the sites of the metastases. So they received a PET scan, so we knew exactly where the lesions were, and then we'd adjust the resistance, aerobic and flexibility training program specifically tailored so that we reduce the risk of any fracture. The second question was, could you exercise them safely, but would it be effective? In these cancer patients that are so unwell, is there any point in exercising? Can their physiology actually respond and improve? So we published a paper back in 2013 reporting the safety and efficacy. Adverse events during exercise sessions, none. Attendance, 20 out of a possible 24. In fact, 70% of the patients came to all 24 sessions. So yes, they will turn up. They will do the exercise even though they have advanced cancer. Compliance was high, tolerance was high, they could work at a decent level here, no exacerbation of bone pain. Next question, so it's safe, but can they respond? Again, the answer is yes. Strength increasing markedly, aerobic fitness, walking speed here. They even increased lean mass, a 1.7 kilo difference between the exercising and usual care groups. And what was particularly pleasing here was physical activity outside of the study increased markedly by almost 25%. So they were walking the dog more, playing golf more, whatever. So on the basis of this, we applied to Movember for funding to run a study in men with advanced prostate cancer, because now we want to know, can we actually extend their survival? Will exercise actually help these men to live longer? And so this is the study. It's called Interval MCRPC, difficult acronym, I know. That's been funded for 10 million Australian dollars by Movember. It's a multinational trial, phase 3 trial, 25 sites around the world, recruitment target of 866 men. We also have a very large translational research aspect here, looking at the mechanisms by which the exercise is actually suppressing the tumour development. Now, this is being led by Edith Cowan University and the University of California, San Francisco. But the primary outcome in this study is overall survival. And we've powered the study on shifting their survival by 2 months. The median survival for these men at this stage of disease is 30 months. So shifting it by 2 months is a good outcome. In fact, it's equal to the improvement in survival reported for the 2 leading drugs used to treat these men at the moment, which is enzalutamide and abiraterone. So that study's ongoing. Going well. So I'll just come back to my point before, that exercise is not a single medicine. We have to be careful about mixing up physical activity and exercise. For example, recommending to your patient, if they have, for example, sarcopenia due to cancer or treatment, recommending them to walk is probably going to be counterproductive. It will probably actually exacerbate the sarcopenia because it will create a greater energy imbalance. So you need a different sort of medicine for that group. You're going to need high-intensity resistance training. As you saw, for managing the bone issues accompanying cancer and treatments requires a highly specific exercise prescription. So I like this diagram from Pedersen and Fabreo here. Nice paper if you get a chance to read it. And what they're actually showing is the muscle system is now known to be the largest endocrine organ in the body. Unless you're overweight and obese, in that case, adipose tissue is the largest endocrine organ in the body. But in a normal person, normal body weight person, the muscle system is constantly pouring out a whole range of hormones and cytokines. And you can see just a few of these listed here. But these are quite powerful substances which impact every single organ system in the body. And so we have to, as a matter of priority, use exercise medicine to maintain the size of this organ, to produce this endogenous medicine. If you like, your muscular system is the pharmacy, the internal pharmacy of the body. So you want to keep it nice and big, so it's got lots of product in it, And you need to actually get it to dispense these medicines quite regularly, and that means just exercising the system. And how you exercise it produces different types of medicine. You exercise one way, it provides antibiotics. You exercise it another way, it produces pain analgesia. You exercise it another way, it produces drugs like brain-derived neurotrophic factor, which are actually protective for the brain. So, very important message, I think, that one. Practical example and translation of this, we have partnered with Genesis Care, which is the largest private medical company in Australia. They have about 27 cancer care centres around the country. And what we're doing is we're actually implementing exercise clinics co-located with their chemotherapy and radiation therapy. So they're actually physically right next to where the patients are receiving therapy. Great convenience. The patients report that it's very convenient. They'll actually turn up and do it, and it's proving highly effective as well. We've just opened our third site in Australia. In December, we'll open a site in Windsor in the UK. So this is what's happening here, is they're getting their pre-treatment, where they have some testing here, some functional tests, etc. We're intervening here. The exercise is prescribed specifically for the patient and the issues that they're facing, and then they're post-assessed. About 6 to 7 weeks generally of radiation therapy or chemotherapy, depending, but it varies quite markedly. So there we've had about 235 patients come through this. We've got pre and post data on about 69 of those patients, a range of cancers, as you can see here. Key is that the compliance is very high. A lot of people say exercise medicine will never work because people won't do it. They won't comply. People don't take their drugs. You know, a massive study published in New England Journal of Medicine showed that at 6 months, 50% of patients are no longer taking their statin therapy. With exercise trials, for a 3-month intervention, we generally see 80% or higher in terms of compliance and retention. At 6 months, it's generally around 70, and even at 12 months, we're seeing 65% or better compliance and adherence to the intervention. So people will adhere to the study. Sadly to say, in particular, if they've got cancer. Adherence in cancer is much, much higher. It's a lot more difficult in metabolic syndrome. I might skip through these. This is just some of the benefits we've seen with this intervention. Increases in upper body and lower body strength, which is really encouraging. And then we've seen significant improvements in walking speed, aerobic capacity here, and functional ability. And you might say, geez, it's not that impressive. This is over the course of chemotherapy or radiation therapy. Normally, the patient would experience a precipitous decline in all of these factors. So we're able to prevent the decline, and in some cases actually enhance their physical capacity. Just to finish off, just want to talk a little bit about the current state of things in Australia. Of course, in Australia, we have Exercise and Sports Science Australia, which is our professional association for our discipline. There's the website there. I think what's been very effective in Australia is that we have an allied health professional called the Accredited Exercise Physiologist. They are now supported by Medicare, and so a patient can be referred to them by their general practitioner and receive consultation with the Accredited Exercise Physiologist. They're 4-year university trained in Australia and have to be accredited by a professional body. There is rebates for them through our Medicare system, and they're now being recognised by the Australian General Practice Network and the Royal Australian College of General Practitioners as the most appropriate allied health professionals for exercise prescription and management, prevention and wellness, secondary management of chronic disease, including cancer. So in Australia, we're finding that the accredited exercise physiologist is playing a critical role in the delivery of exercise medicine in our country. This is an interesting study published last year by Deloitte Access Economics, and this was the actual the results of this particular evaluation, looking at the value in terms of benefit to cost for the consumer of accredited exercise physiologist interventions and selected conditions. And it varies a little bit. Yes, you can see here. For depression, it's about 10.8. So that means for every dollar invested, the consumer gets $10 or $11 worth of benefit. It's not so great for asthma, but the average across these various diseases was in fact a ratio of 10 in terms of benefit to cost. You've had a month of Exercise is Medicine on campus, which is a fantastic initiative. I encourage you to have a look at the various websites. This is the US website where this was initiated by the American College of Sports Medicine. and to several other groups over there as well. It was then brought to Australia about 6 years ago. I've been on the steering committee during that time, and so we've implemented it there in Australia, and it's been, again, highly effective and is really changing, in particular, physician behaviour in terms of having a discussion with their patient about their current physical activity and ways in which they can increase their physical activity because of the well-established health benefits that it has. There's also an association, Clinical Exercise Physiology Association, which is an affiliate of the American College of Sports Medicine, and specifically for clinical exercise physiologists, because that is the allied health professional which is sort of taking the baton in the United States for the delivery of exercise medicine. So I got a little bit quick towards the end, apologise for that, but I think we've got 4 minutes for questions. If anyone's got any questions, once again, thank you. Thank you, Michael. Thank you to the University of Hong Kong. It's an unbelievable honour to actually be here, standing in this lecture hall and presenting some of our work and that of others. And please, if you've got any questions.
Thank you, Professor Newton, for a very educational and somewhat scary talk. I hope everyone's encouraged to do a bit more physical activity. But we've got the room booked till 7:30, but just a couple of questions is probably enough.
It's enough time for the exam, though.
Excellent talk. Thanks very much indeed, Rob. There's a little bit of debate on whether, when you're undertaking heavy resistant exercise, whether you need to push the patient actually through to fatigue or not. Some say yes, some say no.
I'd say no.
You say,
yeah, yeah. No, all of our patients will. So when you prescribe resistance exercise, you usually prescribe an RM, or repetition maximum. So if it's a 6 RM load, it's a weight they can just lift 6 times, and the 6th one is like, I couldn't do another one. We don't push them to that intensity. I think I know we get sufficient benefit just stopping 1 or 2 repetitions before that. That's an excellent question.
Great talk. I enjoyed it a lot, actually. Very informative, very fruitful. I just want to get a quick question about, we want to get people to move. But one of the common reasons is about the lack of time. So that's why recently there's an emerging exercise modality called high-intensity interval training.
Yep.
So I just want to see how would you comment on that?
Yeah, time is a major consideration. We use HIIT training extensively with a wide range of patients. So high-intensity intermittent training, that's training exercise prescribed where you do a repetition of high-intensity exercise. So it might be sprinting on the bicycle, stationary bicycle, and then light pedaling. So you might do a 1 minute on, 1 minute off, or whatever, and we change the ratios, etc. So that's high-intensity intermittent training. It's been shown to be highly effective for managing a wide range of diseases, everything from chronic obstructive pulmonary disease, myocardial infarct, cardiovascular disease, type 2 diabetes. It's been very effective. We're using it in our cancer studies as well. So it does produce entirely different physiological changes, and particularly hormonal changes, to moderate intensity continuous training, or just your normal riding along or normal light jogging. It does produce different effects. It is a different medicine. It is highly effective. Cancer patients, probably more than any other patient, have the issue of time. Okay, because they've got so much going on. There's huge financial implications. They're trying to, balance a whole range of things, family, work, etc. And that's why the current recommendation is to do 150 minutes per week of moderate to vigorous aerobic activity and 2 or more resistance training sessions per week. Well, that's the same recommendations for healthy older adults. And that we find that for many patients, particularly when they're unwell, is that doesn't work. It's too much. It's too much time. It's too much energy expenditure, and so we're relying a lot on higher quality, higher fidelity exercise, but less quantity of exercise. So yeah, I mean, some of our patients come in and it's 20, 30 minutes, that's it. That's why the recommendation is problematic if you say to your patient, I need you to go out and walk, for 50 minutes a day. I don't have 50 minutes a day to go out and exercise. That's a problem. Sorry.
Well, this is very fantastic talk. Because there are so many types of exercise for chronic cancer patients or chronic patients or cancer patients, what type of exercise have been shown to be most effective or most helpful for that kind of patients? Okay.
First key message is, if the patient is more physically active in general, regardless of the type of exercise, they'll actually improve their chances of survival. and they'll have less chance of recurrence. However, we can be much more prescriptive to that and have more tailored medicine. And what we do is we tailor the medicine to impact the issue which is most likely to cause them the greatest morbidity or mortality. And so if the patient, for example, is in a breast cancer patient who has been receiving hormone therapy and has issues around metabolic syndrome, we really target trying to actually turn that around, because they're probably going to die of cardiovascular disease. Similarly, if we look at we're doing a study at the moment in mesothelioma. So this is a terrible disease. The survival rate, no one survives it. It can't be cured. And the greatest issue is that the patient just disappears. They just shrink away because the cancer just draws so much glucose out of their system. So for them, we're just doing very targeted resistance training to try and hold some level of muscle and bone on them to maintain some level of function. So all physical activity will be good, but we need to be more sophisticated. You know, these patients are in a bad place, and we need to spend the time to actually prescribe an exercise prescription which is going to target the issues which is impacting them the most. What's going to kill them first? Let's fix that. We'll worry about the other things later.